But I'm like, that's a great idea. He needs to be introduced to other kids with the same interests, other kids who may communicate the same way. I'd much rather have y'all spend the time trying to get friends with people who are like him than teaching him how to act quote unquote normal, So more, and then also things like teaching him to recognize uh, fake friends, right? When there are people trying to take advantage of him, people, because he tends to be pretty trusting. Some would say gullible. And so it's like, we need to be able to teach our kids to recognize that, you paying for ice cream every day after school, that's the reason why they invite you along. You need to know that that they're being tricky. In medicine, they've found that congruence, the cultural and linguistic congruence is important um, during medical healthcare interactions. And, when you have that incongruence, like a doctor who does not speak the same language as the patient, a patient who uses an AAC device with a verbal doctor, um, patients in general who have communication disorders, that's predictive of more medical errors. There are a lot of important questions that healthcare providers rely on the patients to ask. But if we know that this is a group of women who've had a stroke, um, who don't tend to ask questions as much because of the stroke, because of that right hemisphere stroke, then as healthcare providers, we need to be proactive and provide more information, perhaps in a different way. Maybe more visuals. Just know, simply saying, do you have any questions? Most people, whether they've had a stroke or not, whatever culture they're from, are usually not going to say they have more questions, right? For different reasons. If they're uncomfortable with the person, if they're timid. There are a lot of reasons why people don't ask questions. And so we feel, as far as speech pathologists, the onus is on us to make sure the patients understand what's happening. It's on us to understand that this patient might not ask a lot of questions. They might not ask the right questions. What can we do to mitigate that situation?
I am very excited to be making another video with a friend and collaborator who is a speech therapist and autism researcher. So would you be willing to introduce yourself and share a bit about your research and also what research results you've been the most surprised or interested to discover?
Okay. My name is Danai Fannin. I'm an associate professor at North Carolina Central University, where we have a speech language pathology master's program to train speech pathologists. And I've been there since 2018, and I've also been doing collaborations with researchers at the Duke Autism Center of Excellence for the past few years. Um, as a speech pathologist, what we do is help people with communication, try to either establish communication or enhance it. So there are a variety of ways that we help across the lifespan. And then also, if people have swallowing disorders. So if you've had a stroke or dysphagia is what the swallowing disorder is, but dementia, so some degenerative things. So at those points, we're trying to preserve communication, and it's a lot of teaching family members how to communicate with the patient. And then with kids, we'll be in schools, if not in like outpatient therapy in a hospital, but in schools, we work on speech, language, uh, other, voice as well, and also like lisps, R's, a wide variety of things that we do. My specific interest is in child language. So child language disorders, delays, and I have a specific focus on autism as far as helping with communication for autistic people. And then I also have an interest in pragmatic disorders, and pragmatics is the language domain where how you use language. So a lot of people, they have a great vocabulary or they're able to form sentences, but they don't know the right time and place to use their language. So a pragmatic disorder would look like, um, you know, interrupting people or not understanding jokes, not understanding people who are being sarcastic, and just not picking up on those cues. So sometimes you'll see with autistic people, when they're evaluated, the tests will say they have pragmatic disorders. What we're finding is their pragmatic differences. So there are a lot of autistic people as well as non-autistic people who don't read people well, right? Or who communicate differently, socialize differently. And, things have changed over the past few years with the neurodiversity movement from seeing how autistic people communicate as a disorder and more towards it's a difference. Um, and that there are people who are neurodivergent who understand each other perfectly well, and neurotypical people who understand each other perfectly well. When we have the standard set at neurotypical people because autistic people can't read neurotypical people's social cues, they're the ones with the disorder. Now we're trying to shift to, well, neurotypical people can't read autistic people's social cues either. So it goes both ways. And that's called the double empathy problem, but and you can look that up. That's not my specific area of research interest, but what we're trying to do is say we're working on social skills in the schools. Uh, Rather than trying to make someone or a child learn to socialize with neurotypical kids, how about we try to link them up with other neurodivergent kids or people who socialize like they do? Let's try to have them make friends with people who have the same interests, just like we do with neurotypical people. We look for people who also like video games or, reading books. And so that's an example of, pragmatics in with autistic people I'm interested in. I'm also interested in an actual apragmatism, a pragmatic disorder that happens after right hemisphere stroke. My most recent paper is on differences in question asking for women, differences between Black and white women, those who've had stroke and those who have not had stroke. And an interesting finding, we found that both the controls, the Black women who had not had a stroke and those who had a stroke, they asked fewer questions. Um, than the white women. Now, white women who had a stroke, they still asked fewer questions than those who had not had a stroke. So everyone who had had right hemisphere damage are showing that sign, a significant difference in the number of questions they were asking. But we saw that similar decrease in question asking with typically with the ones who had not had a stroke, with Black women. So that just showed us that we have more research to do because certain cultures, um, we would call them high context cultures, are cultures that use other types of pragmatic supports for communication, like gestures, um, signs, visual cues, demonstration of how to do something versus talking a lot. And so if you're showing a child how to build a bookcase in a high context culture, there will be less talking from the adult, less verbal instruction, and just actually showing them how to use the hammer and the nail and demonstrating how to do the task, using more visual cues. So that would be a characteristic of high context culture, which those of African descent would fall in that category. So our question is, were these Black women just um, showing signs of being from high context? Had they not had a stroke, would they have been asking fewer questions anyway? Um, but whereas we have the low context culture, which is more written language, more verbal, so more explanation in, the type of language stimulation you would provide to a child when you're teaching them how to build the bookshelf. And that is how our educational system is set up, low context. They tell you, okay, read these 5 chapters in the history book and you have a test on it next week, versus more active learning, demonstrations, different forms of media that would be more high context. So in that study, the research assistants we had doing the conversation with the women who had had a stroke and had not had the stroke, they were all graduate student research assistants, and they were all young women, young white women. Those are our graduate students. So the question was, might have the Black participants not talked as much because they were with someone incongruent to them, someone who is younger. So because the task they were doing was, we just told the participants to, hi, this is so and so, get to know them. So they talked for 15 minutes. So we were trying to see what questions they would ask to get to know them. Um, and that's important. In medicine, they found that congruence, the cultural and linguistic congruence, is important um, during medical healthcare interactions. And when you have that incongruence, like a doctor who does not speak the same language as the patient, a patient who uses an AAC device with a verbal doctor, um, patients in general who have communication disorders, that's predictive of more medical errors. They found this with patients with communication disabilities, patients who are women. And then, most healthcare providers are not from high context cultures right now. And what we would hope from this research, this study, like why does it matter that they didn't ask as many questions? We are applying this to, what about when they're seeing their doctor after the stroke? That's when we find out if we're taking the medicine correctly. You have to ask those questions if you didn't understand, right? The directions on the bottle. Um, Questions about, well, I've got this symptom, or I'm feeling this way, or I'm not sure how to do this procedure, and so on. There are a lot of important questions that healthcare providers rely on the patients to ask. But if we know that this is a group of women who've had a stroke, um, who don't tend to ask questions as much because of the stroke, because of that right hemisphere stroke, then as healthcare providers, we need to be proactive and provide more information, perhaps in a different way. Maybe more visuals, just know, simply saying, do you have any questions? Most people, whether they've had a stroke or not, whatever culture they're from, are usually not going to say they have more questions, right? For different reasons. If they're uncomfortable with the person, if they're timid, if they don't want to look dumb. There are a lot of reasons why people don't ask questions. And so we feel, as far as speech pathologists, the onus is on us to make sure the patients understand what's happening, It's on us to understand that this patient might not ask a lot of questions. They might not ask the right questions. What can we do to mitigate that situation? So, but again, we still need to do more research to see if it was an issue of the communication partner. Um, were we just seeing cultural differences? We definitely did see fewer questions from all of the women who had had a stroke. So, I mean, that is a finding that hadn't been, shown before in that type of situation, that conversation. So, my friend Jamila Minga, she's a professor at Duke, and she does this right hemisphere damage stroke. And I do work with her on the health disparities branch of her research. Um, and for my research with autism, I um, I got a grant from the ASHA Foundation in 2020 to look at the experiences of Black caregivers and then teachers in schools during the identification process in the school system. So, what are their experiences getting a diagnosis or getting identified and placed in the school system as having a primary identification of autism? Lauren Franz and um, and some other researchers at Duke and I had done an analysis of all the public school records in North Carolina, looking at the primary identification of all the children in the public schools. Um, and what we found was that children in rural areas who were bilingual and also Black all had a higher likelihood of being identified with intellectual disability instead of autism. And there are no biological reasons why there should be a difference. And we controlled for things like family, history. If they have intellectual disability, we controlled for all of that, and there's no reason why there should be racial or geographical differences in intellectual disability and autism. So the kids in Durham, they had a higher chance of getting identified as having autism as a primary identification. So so that study is what led to my ASHA Foundation study, trying to just talk to people qualitatively to see their experiences with identification, what they thought about it. Because I'm curious to know why we have these differences. And the reason it matters, that the specific identification matters, um, is that the classrooms are set up differently. The way you educate people are different depending on their primary identification. So, and there are autistic children who are also have intellectual disability. That is definitely a group of, autistic people. But, um, you know, when a child has an autism diagnosis, they or identification in schools, they don't have to have a medical diagnosis. They may be in a self-contained classroom with other autistic children, or they may be mainstreamed into the gen ed classroom um, and with supports. Um, and then the children with intellectual disability may be in a different classroom. Uh, as far as intellectual disability, it's kind of tricky how it's identified. And there's, it's not a foolproof way. And some people who just don't talk, children who don't talk, have been misidentified as having intellectual disability. And when you have the intellectual disability identification, sometimes the teacher's expectations are low. Some schools, they won't even try to teach you, to read with that intellectual disability. Whereas if you have an autism identification, they may say, well, they'll be able to learn. Now, I mean, that's a separate problem with intellectual disability. We need them to still be learning in school. That's what special ed teachers are for. They still need to be learning, but we know that the expectations are lower. And so we don't want misidentification. It's can be a missed opportunity for children who are autistic, if they're misidentified, or any children who are not talking, that's a missed opportunity as well. So that's, one of the things that speech pathologists do. We can find other ways to communicate. If a child's not speaking, we can set them up with AAC devices, or speech generating devices, or low tech, a page with icons and words that they can use and point to communicate. There are a lot of different forms of alternative and augmentative communication. Um, but that's part of our goal. And what I found from my ASHA Foundation study, I'm still doing analysis, is that the Black caregivers are often told, even from their doctors, that let's just wait. um, there's nothing wrong with their child, or they're diagnosed with a behavior disorder, a psychiatric disorder. um, a lot of pushback, having to go to multiple places to get identification. Also, delayed identification. So, it's not until the child's 14 that they finally got an identification. I interviewed gen ed teachers, English as a second language teachers, speech pathologists, and special ed teachers. And they had similar stories as well. A special ed teacher said there was a ninth grader who had not spoken a word or signed anything their whole time there, until she got to the school and asked about a speech pathologist. So they'd never gotten any, evaluation, and they did set them up with a device. At our clinic at North Carolina Central University, we had a 21-year-old man come with his mother, and Dr. Minga, the one I work with the right hemisphere damage research, she also used to do a lot of AAC evaluations when she worked for the state. So she did an evaluation for AAC, and set him up with a speech generating device. In 2 weeks he was using it. He was finding videos on YouTube that he liked to watch. There was one that he liked that had someone playing a tambourine. Even though he was pressing the device for tambourine, he started saying tambourine. So these AAC devices, speech generating devices, do not stop the ability to eventually speak. People can be speaking and use the device. Um, but what Dr. Minga found, and our former clinic director, Ms. B. Ryder, was that they think he's been reading all this time. So his mother, for 21 years, thought he was illiterate. And that this was a revelation to her, and just shows just the poor educational situation he was in. His mother said they would put him in the classroom, just set him at a table, and he sat there all day. And he was also Black, and we see these disparities in the placements in the school systems. We see that these, as our data showed, potential misidentification of intellectual disability instead of autism. But receptively, he was still learning, he was still reading, he knew what to find on YouTube. And just by giving him this mode of communication, this speech generating device, it's opened up a new world and possibilities for him to be reading and for them to find out he's literate. So, that's the leads to my current research interest, which is in early identification of children for autism. And that's the research I've been working on with the Duke Autism Centers of Excellence. What in their first 5 years of the their grant, um, all of the participants come from, they're all patients at the Duke Pediatric Outpatient Clinics. They're all from around Durham. And Durham is almost 50% Black. Um, and, their sample that they got, their initial sample was representative of the town. So the categories they have is Hispanic, Asian, Black, and white. And what they found was that the Black participants, they joined the study um, and did the screening, showing that they may have autistic traits. Um, but when asked if they would like to continue in the study and do a full evaluation, the Black families more significantly more opted out. It did not continue in the study. So with Durham being a town, it's not a supply and demand issue. There are enough African Americans in Durham, North Carolina, and that entered their study initially for it to not be so many fewer participating in the study. So that's one of my research aims is going to be interviewing Black caregivers in this new iteration of the Duke Autism Center of Excellence to see about how we can better recruit and retain Black families in, autism studies of early childhood. Usually we want to be talking to the actual autistic participants, but when you're talking about early intervention, like birth to 3, the parents are really the only ones you could talk to. Um, that's one of the aims is to look at how to improve the recruitment and retention of Black caregivers and finding out from them what they think, for them to tell us. There are other researchers who've looked at this question, but this specific um, study involves digital health care tools, like the Sense to Know application that the Duke Autism Centers of Excellence has developed. And so, what the second aim of my study is going to look at the Black caregivers, what they think about the appropriateness, acceptability, and the feasibility of using this Sense to Know application. So it's a screening tool. It's not a diagnosis tool, but it's a screening tool. It's an app that you can use on your phone or your tablet. And the baby, so they're starting out at 18 months old, they look at the screen and there's a bubble popping game. And then there's, people on the video saying hello to the child and doing different like social communicative things that we normally do and looking at the child for the response, except the application is using machine learning to look at the child's facial features, their movements, also their posture. What they found in the previous, trial is that there are differences in how autistic children, physically their movements, and how they respond to the application that could indicate autistic traits. But the parents are actually going to be using this application. So I'm going to be interviewing the caregivers about what they thought about the application and potentially any improvements or adjustments they might say would be more helpful. And then the third aim is actually um, based on how they feel about, first of all, their pediatrician's cultural responsiveness during this diagnostic process, during the past year, actually. And, just what they think about the pediatrician's cultural responsiveness. And then also, Duke ACE is developing what they call clinical decision support for the pediatricians. Um, the traditional screening process for autism is the pediatrician interviewing the family members, asking them, does your child point? Do they turn when you call their name? Do they laugh when you tickle them? Different behavioral questions. That's how we traditionally screen for autism. But what some other researchers have found is that for Latina families, 68% of the time, even when the child screened positive for autistic traits, the pediatrician did not refer the child to early intervention. That's something else where we don't know why that is. Just like we don't know why in the rural areas they're identifying children differently, with intellectual disability instead of autism. We don't know why the pediatricians are not referring all of the children who screen positive for early intervention, which is that birth to three, the federally funded birth to three program, where all families, all residents of the United States, your children can go for things like a nutritionist, speech, occupational therapy, physical therapy, all types of therapies. And it's maintained by the state, paid for by the state. And, early intervention can be helpful. The earlier the child can get a communication system down, the better for them. That can help reduce their challenges, right? Many times they may have a meltdown because they can't tell you that they're thirsty. So if we can get a way for them to communicate in early childhood, that's the what we want to see with early intervention, but the pediatricians are not necessarily referring children to early intervention. So this communicate clinical decision support, an example could be um, if they screen positive on the screener and they also show other signs in their electronic medical records, like, the parent said the child's not talking, or the child's really clumsy, or the child has gastrointestinal issues, right? They're constipated all the time. There are a lot of different signs in early childhood that when you put them all together, in retrospect, you could say, wow, my child is autistic. I should have known then. That's how it was for both of my two children. When we look back, there's sleep apnea. There were so many signs that the pediatrician did not put together for us. And I, someone who should have known, doing research, should have known, but it's, the signs are so subtle, and, you know, a certain behavior may look like another thing, developmental, delay. So this clinical decision support could say to the pediatrician, like, okay, you can't escape out of this screen until you refer them to early intervention. So basically helping them make these decisions instead of leaving it up to subjective opinion as to why, oh, even though this child is showing autistic traits, I don't think they need a referral because they're a boy and boys talk later than girls anyway. That's a common reason why there's this wait and see approach. So what I'm going to do is present this clinical decision support system to the Black caregivers and have them tell us what they think about it, how helpful and acceptable they think it will be. So yeah, so I'll interview the Black caregivers about what they think about this clinical decision support. So the team, Dr. Franz's team, they're putting it together and they're interviewing the pediatricians and developing it along with stakeholders in the community, and they'll get the perspective from some parents also, right? Because, as patients, we're usually on the other side, like using my chart or whatever, but if they were able to see what the doctor sees when it comes to these doctor visits, and when they're about to make that decision whether to refer the child, it'll be interesting, I think, to hear from the caregivers. So that's going to start And as soon as the Institutional Review Board approves my amendment to the Duke ACE studies. So that's what I'm going to be working on for the next 5 years. Um, but with the whole goal of improving that early identification and also retention and recruitment of Black participants in research, in autism research.
Yeah, thank you so much for that overview. I have a couple questions that weren't on the list, so no pressure to answer them. But
Okay.
the first one is kind of a very specific question. But when you were discussing the study on right hemisphere brain damage and how
Hmm.
um the graduate students conducting the study were younger white women,
Hmm.
was there any decrease in question asking related to age as well? For example, if the participants were older, did it seem like the age gap maybe was also leading to lower question rate?
So the range of participants, I think there was someone as young as in their 40s, but they tend to, people who have stroke tend to be older. Um, and in fact, but in fact, we're finding more people having strokes younger. So that's something coming up. Dr. Minga has like a group of like 900 people who've had right hemisphere strokes at Duke hospitals. So we're going to be looking at that data set. Um, but yeah, I mean, it could be a difference with the ages. Like, when they're older, it's like they're talking to maybe a grandchild, when our grad students usually tend to be in their 20s. Um, and so it might be that, difference. So we considered the generational difference as well as the racial difference. So for her next study, we're going to have matched by race, the communication partners, and age, and hopefully gender. It's much more difficult to find Black male, speech pathology students. But we are going to be trying to match that better to see if it is. It may not be the reason that there were differences, but we want to make sure to check.
Thank you so much for that answer. One other question I have is just I would be really curious to hear any thoughts or conjectures you have on the reasoning behind why the retention rate in the ACE study was so much lower for Black families, like anything that inaccessible that might be
Yeah.
part of the research project or design.
So, like other studies have found, multiple times issues of transportation, having to come to a lab, um, when the data is collected. It might be when certain families who work multiple jobs work, or families who work nights, things like that. But these participants, they at least live here in Durham. When I was a postdoc at UCLA, and we did clinical trials for autism, and I did the control group. I collected all the data for the control group, which was a parent education program, and I went out to the families' homes. So because it's so complicated to get anywhere in LA to UCLA, it takes forever. I lived in Pasadena, it took me 2 hours one way to get 28 miles. uh, the Baltimore site at Johns Hopkins, they had this trouble. One of the researchers there did a study on the Black participants and why they had problems with retention. And they had that problem because they were having the parents come to the clinic. So um, like we learned from that we do need to adjust as far as, being more accessible. Um, because of the pandemic, many studies went online, and there's a lot of data collection done via Zoom. So that kind of mitigates the problem as far as the transportation. or the convenience, that research assistants are going to need to be able to do things on the weekend or in the evening if that's more convenient. Um, but, once that's all fixed, you still have, attrition from the studies. And so some of the thoughts we know that based on the history of the United States and doing research on Black people who did not consent, and this is all the way back to slavery, right? And the field of gynecology was based on doing research without anesthesia on enslaved women, right? So there's a big distrust. There's the Tuskegee Project, you've probably heard of in your training for us being able to do research, the syphilis study where Black men were injected with syphilis. That still comes up in when during the pandemic, when we were being all told to take the vaccines. Many Black people cited that Tuskegee study that Black people do not trust researchers, medical researchers. Um, so that's something to overcome. And it's one of the reasons why we try to do more community engaged research. We just had a meeting earlier this week talking about how to disseminate our research results to all of the participants, not just Black participants, but all the participants. People need to know and want to know what their participation results in, or how it's helping, because not all studies are intervention studies. This study is not intervention, they're giving their time to talk to me. Um, and it's, meant to help greater society. But, if you're from a group of people who's been, who has distrust of researchers, that's part of the problem. Um, Another issue related to that is a collection of biological specimens, so the genetic studies. Those are, have an increased chance of Black people distrusting those studies, because what are you going to do with my genetic information? Um, all people in general, anyone working really distrusts anything once you start talking about genetics, because it's a reason for medical insurance to not cover you. That's a myth, I mean, it is true. It has been true before that, but like, with the Affordable Care Act, some of that pre-existing condition, problems, restrictions had been lifted. But, if a medical insurance company finds out that you have certain genes, um, that might make you ineligible for insurance. That's another concern. I know that Black people have when asked to do these genetic autism studies. We aren't doing the genetic studies here, but at UCLA, the Autism Center of Excellence there is doing genetic studies, and they have hired, Black program coordinators, research assistants, researchers to work on this study and try to figure out ways um, to convey the importance of the genetic studies, or why they should want to contribute. And I also suggested things like the mobile unit at NCCU. We have a mobile van where we go out all around the state. We do hearing screenings, we do diabetes testing. The nursing department does a lot of different types of checks for people, and that takes care of that transportation issue. But going into the community, building relationships, first is what's needed before just coming in there and saying, hey, we want to do research. North Carolina Central University is a historically Black university. So yeah, so the I'll interview the Black caregivers about what they think about this clinical decision support. So the team, Dr. Franz's team, they're putting it together and they're interviewing the pediatricians and developing it along with stakeholders in the community, and they'll get the perspective from some parents also, right? Because, you know, as patients, we're usually on the other side, like using my chart or whatever, but if they were able to see what the doctor sees when it comes to you know, these doctor visits and when they're about to make that decision whether to refer the child, you know, it'll be interesting, I think, to hear from the caregivers. So that's going to start as soon as the Institutional Review Board approves my amendment to the Duke ACE studies. So that's what I'm going to be working on for the next 5 years. Um, but you know, with the whole goal of improving that early identification and also retention and recruitment of Black participants in research, in autism research.
Yeah, thank you so much for that overview. I have a couple questions that weren't on the list, so no pressure to answer them.
Okay.
But the first one is kind of a very specific question. But when you were discussing the study on right hemisphere brain damage and how
Hmm.
um the graduate students conducting the study were younger white women,
Hmm.
was there any decrease in question asking related to age as well? For example, if the participants were older, did it seem like the age gap maybe was also leading to a lower question rate?
So the range of participants, I think there was someone as young as in their 40s, but they tend to, you know, people who have stroke tend to be older. Um, and in fact, but in fact, we're finding more people having strokes younger. So that's something coming up. Dr. Minga has like a group of like 900 people who've had right hemisphere strokes at Duke hospitals. So we're going to be looking at that data set. Um, but yeah, I mean, it could be a difference with the ages. Like, you know, when they're older, it's like they're talking to maybe a grandchild, you know, when our grad students usually tend to be in their 20s. Um, and so it might be that, you know, difference. So we considered the generational difference as well as the racial difference. So for her next study, we're going to have matched by race, the communication partners, and age, and hopefully gender. It's much more difficult to find Black male, you know, speech pathology students. But we are going to be trying to match that better to see if it is. It may not be the reason that there were differences, but we want to make sure to check.
Thank you so much for that answer. One other question I have is just I would be really curious to hear any thoughts or conjectures you have on the reasoning behind why the retention rate in the ACE study was so much lower for Black families, like anything that inaccessible that might
Yeah.
be part of the research project or design.
So, like other studies have found, you know, multiple times issues of transportation, having to come to a lab, um, you know, when the data is collected. It might be when families who work multiple jobs work, or families who work nights, things like that. But these participants, they at least live here in Durham. When I was a postdoc at UCLA, and we did clinical trials for autism, and I did the control group. I collected all the data for the control group, which was a parent education program, and I went out to the families' homes. So because it's so complicated to get anywhere in LA, to UCLA. It takes forever. I lived in Pasadena. It took me 2 hours one way to get 28 miles. Uh, the Baltimore site at Johns Hopkins, they had this trouble. One of the researchers there did a study on the Black participants and why they had problems with retention. And they had that problem because they were having the parents come to the clinic. So um, like we learned from that we do need to adjust as far as, being more accessible. Um, because of the pandemic, many studies went online and there's a lot of data collection done via Zoom. So that kind of mitigates the problem, um, as far as the transportation or the convenience, that research assistants are going to need to be able to do things on the weekend or in the evening if that's more convenient. Um, but, once that's all fixed, you still have, attrition from the studies. And so some of the thoughts we know that, based on the history of the United States and doing research on, Black people who did not consent, and this is all the way back to slavery, right? And the field of gynecology was based on doing research without anesthesia on enslaved women, right? So there's a big distrust. There's the Tuskegee Project, you've probably heard of, in your training for us doing, being able to do research, the syphilis study where Black men were injected with syphilis. That still comes up in, when during the pandemic, when we were being all told to take the vaccines. Many Black people cited that Tuskegee study that Black people do not trust researchers, medical researchers. Um, so that's something to overcome. And it's one of the reasons why we try to do more community engaged research. We just had a meeting earlier this week talking about how to disseminate our research results to all of the participants, not just Black participants, but all the participants. People need to know and want to know what their participation results in, or how it's helping, because not all studies are intervention studies. This study is not intervention, they're giving their time to talk to me. Um, and it's, meant to help greater society. But, if you're from a group of people who's been, who has distrust of researchers, that's part of the problem. Um, Another issue related to that is a collection of biological specimens, so the genetic studies. Those are, have an increased chance of Black people distrusting those studies because what are you going to do with my genetic information? Um, all people in general, anyone working really, distrusts anything once you start talking about genetics because it's a reason for medical insurance to not cover you. That's a myth, I mean, it is true. It has been true before that, but like, with the Affordable Care Act, some of that pre-existing condition, problems, restrictions had been lifted. But, if a medical insurance company finds out that you have certain genes, um, that might make you ineligible for insurance. That's another concern. I know that Black people have, when asked to do these genetic autism studies. We aren't doing the genetic studies here, but at UCLA, the Autism Center of Excellence there is doing genetic studies, and they, have hired, Black program coordinators, research assistants, researchers to work on this study and try to figure out ways, um, to convey the importance of the genetic studies, or why they should want to contribute. And I also suggested things like the mobile unit at NCCU. We have a mobile van where we go out all around the state. We do hearing screenings, we do diabetes testing. The nursing department does a lot of different types of checks for people, and that takes care of that transportation issue. But going into the community, building relationships, first is what's needed before just coming in there and saying, hey, we want to do research. North Carolina Central University is a historically Black university, but North Carolina Central University is a historically Black college, but that doesn't mean they have to trust us, you know? We're still a university, we're still an ivory tower, and we've spent years trying to build relationships. There in the rural areas like Halifax County, we have the different Indigenous American tribes there, the Halawa Saponi, and, I wanted to do research there. They have an early childhood preschool there for kids uh, with identification, um, with autism identification. I wanted to do research there, and they were like, we're still working on building that relationship and that trust. I'm Black, but I'm not Indigenous American, right? So they don't have to trust me. So I think just building that trust and not just going into a community and conducting a study and leaving, and not following through with promises that are often made initially when coming to do research. I think that's something that might help, and something that all of us, the researchers, need to work on just better dissemination of the results and continued engagement. My study with the Duke ACE is going to be 3 years long. So I want to make sure to retain the participants. And so part of my aim is to see how to keep Black participants in for an extended period of time, because we want to see how their children are developing as well. Those are part of aims of these studies. And so, um, yeah, there are a lot of different reasons. Things are getting better. Amazingly, even though they found that significantly fewer participants decided to continue in the study last time, that's still better than it was before, and nationwide, all researchers are dealing with the same issue on how to diversify the research samples.
Yeah, thanks so much for that answer. And I I think that um sorry, I'm blanking on what I was gonna say, but essentially there's so much valuable information to be gained about participatory research. I feel like we're at kind of just the beginning stages or like
Yeah.
first step towards participatory research, but then to make it truly participatory and which will make the research stronger in general as well. Like there's no downside to it.
Yeah.
Something
Yeah.
uh but one question that I am especially eager to ask, and that I think is actually on the question list is related to what you mentioned earlier about your work on the right hemisphere brain damage research.
Mhm.
How could that be applied to a related but completely different setting like the IEP process? So, for example, how can the IEP process adjust for different question asking patterns or um, I guess like as you're mentioning the high context versus low context environments that people might be coming from to make it more accessible to yeah, people from all backgrounds.
Yeah, yeah, we definitely, at least I've been taught, since I would, started grad school 24 years ago, been taught to be more culturally responsive in these IEP meetings. We need to learn about the background of the families, have some basics, what's in our textbook, is generalizations, right? And there are always individual differences within cultures. So we definitely don't want to generalize, but knowing particular things, that are characteristic of a culture, like are they high versus low context, can be really important. Um, for example, like I did my clinical fellowship, which is like after you graduate with the master's in speech pathology, you have to work under a speech pathologist supervision for a year before you get your license and certification. So that's that clinical fellowship. I did that in Dallas, Texas, in 3 elementary schools. Um, and 97% of the families were from Spanish speaking, children were from Spanish speaking homes. And I'm not bilingual in Spanish. And that is the majority of speech pathologists are monolingual English speakers. And so we needed to learn. I learned from a professor during grad school. She said that, who was Mexican, she said that, the Spanish word for teacher is maestro, and, we would translate that into master, right? And it just shows how much teachers are revered in Mexican culture versus here in the US. Unfortunately, Americans don't tend to revere teachers. And it's not the same level of respect um, that in Mexican culture. So that can be a downfall during the IEP meeting if the parent thinks something is wrong or their child's not getting services they want, but they're like, but this is the teacher, they're always right. How Americans tend to think of doctors that way, right? The doctor, whatever they say, they're brilliant, everything they say is right, and don't question it. And so our advice from our professor, Dr. Kaiser, she was saying that we need to be advocates for these families in the IEP meeting. Um, she would tell us, don't say any questions, at the end of the meeting. She said invariably, especially if English is not their first language and they don't feel proficient in it, they're not going to ask you a question. We need to be reading cues in the IEP meeting. The way that reading cues for comprehension using interpreters in their first language. We need to insist on that in the IEP meetings. And have a trained interpreter, not just anyone who speaks Spanish, but we need to have people who are familiar with the process, familiar with the language that we use, and are able to explain it and also able to convey to us whether, the family understands. Um, but being advocates for families that are traditionally disenfranchised, immigrants, uh, Black people in the US, poor people, right? People from low socioeconomic status homes, low income homes, and that's regardless of income. I've witnessed it where they have been treated a certain way um, because they can get away with it, right? That because the IEP team can get away with it. There may be a school with mixed incomes, and it's like, okay, why do the kids from this neighborhood don't get integrated into the classroom with supports? They're always put in the most restrictive environment when the federal government says we're supposed to try to get children in the least restrictive environment. And the self-contained classroom, I'm all for it. That is, some people need that. My daughter is in a self-contained classroom, and it's the best place for her. It's the least restrictive for her because when she would go into the mainstream classroom, there were restrictions put on what she can say, what she can do. Can she get up and walk around, right? Will the district give her a one-on-one aid? If they don't, then all she's going to be doing in that class is getting in trouble, right? So her classroom setup is great. Whereas her brother, who's also autistic, he's been mainstreamed in the gen ed, um, the whole time. And that's the least restrictive environment for him. Um, but, we do see differences in placements to children. So a Black and white boys, especially, can have the same evaluation results, the same profiles, but the IEP team will more often put the Black boy in the self-contained classroom versus mainstreamed in the with the white boy in the main classroom. Um, so, those are, as far as the IEP team, the your question about the question asking, I think, I tell my students, and I believe in providing as much information as possible. And, advocating for the parents. If the parents seem uneasy about some decision, asking them, do you agree with this? Telling them, you don't have to sign this until you agree with it. Um, do you want, when the teacher or the SLP says, we don't have money for a speech generating device, telling the family that you don't have to settle for that, that if it's needed, the district is supposed to pay for it. These are things, people who aren't proficient in English are not going to speak up and say. These are things people from low income homes, people who are have lower education levels. There's a lot of things, that um they may not feel comfortable speaking out about. So I said, even if you're the only person on the IEP team being difficult, um, at least you tried. And, it's your job to make sure that the parents get their message out, what they want. Um, I also think the clinical decision support applies to IEP means. That's my long-term goal, right? Once, Dr. Franz and Duke Ace have come up with this clinical decision support for the uh, pediatricians, is there a more structured, objective way we could have clinical decision support for the IEP team? The IEP teams consist of, like, usually the assistant principal, the special ed teacher, the gen ed teacher, and then any pertinent specialists like a PT, OT, psychologist, counselor, uh, all of these different opinions, different levels of training, and then the implicit bias that comes in already, with a group of people. That's why we're getting these different identifications. Um, I think there's too much room for subjectivity. In my interviews for the ASHA Foundation study, I interviewed an English as a second language teacher, and he said he had a student come to his classroom um, from Venezuela, had had an IEP there. He said it took a while for us to get the IEP file from Venezuela, but we did get it. And he said, I presented it to the IEP team. And he said every time the case manager, the coordinator, would say, no, let's wait, kept putting the meeting off. So he said for a whole year, this student did not receive special ed services. And this teacher said, I later found out that this teacher didn't like people like me. And I said, people like you. And he said, he didn't like immigrants from South America. And he said, I found out that he had said some racist things. And that's why I think this child did not get an IEP for a year. Um, that's explicit bias, right? If that were, if that it was the reason why But implicit bias certainly played a role in that amongst the whole team. No child should come to a new school and for a year not get an evaluation for no reason, especially with the teacher, the English ESL teacher insisting. And this ESL teacher is not trained in special education, but he knew something was happening and he knew he had already had an IEP. So hopefully things like clinical decision support can help mitigate this implicit bias on these IEP teams. It can say that this Black boy and this white boy, they have the same profile, unless you all come up with a better reason why they both should not be mainstreamed. That needs to be the placement. I would hope some type of clinical decision support like that could be applied to school systems to make the decisions easier, because they are difficult decisions. It's hard to tell exactly. And, I interviewed speech pathologists and they would say, we don't diagnose autism. So I don't feel comfortable even saying anything to the parents if I'm seeing signs. Um, and, my response was, yeah, we don't do medical diagnosis, certainly not. And medical insurance will not pay, for therapy for a diagnosis that comes from a school. However, we do educational identification. We can, say this child has educational autism. That's what we say, and we should still be moving forward with trying to get placements and therapy. And, the first step is, if you see a sign, say something to the parents. They may have no idea. And, that I asked them questions like, what about your bilingual families and your Black families? Do you think they're um, as open to you saying, that your child might be showing autistic traits? And, some of them were apprehensive about that. They said, well, I don't know if they know about autism. And whereas I would, for everyone, anyone, if I see a sign, and I know people get upset, if you're your niece or nephew and you say something to your sister-in-law, they're going to get mad. But I tell my students, they'll be mad, but oh well, just don't, as long as you don't belabor it and don't keep talking about it, just know that you said something, because you might be the fourth person. Their daycare teachers probably said something, another family members probably said something, and maybe you're the final person that makes them um, ask the doctor about it and get an evaluation. Um, but that there so many moving parts when it comes to identification, um, you know, and accurate identification. So I think clinical decision support could really help. And then I also think that in IEP meetings, us knowing that the parents aren't going to ask questions, that we need to be more proactive, is really important too.
Yeah, thank you so much for that answer. I think in terms of proactivity, I've always thought it would be really neat, at least personally helpful, if schools had a, condensed, not too lengthy checklist of things that they're supposed to be able to offer if a child needs it. 'Cause
Yeah,
at least initially, I
yeah.
wasn't even really sure what things were feasible to ask, what things, simply couldn't be done.
Yeah, that'd be a great idea.
One, you already kind of answered a lot of the questions I was initially going to ask about changes to the IEP process, but one specific area that I would be really curious to hear your thoughts on would be any common goals that you see, either related to speech or just in general, that you would like to see changed, or common goals that you think maybe aren't actually that impactful for quality of life in the long run, or goals that you'd like to see added that schools typically aren't using currently.
Like goals people write for therapy.
Yeah, like I
Yeah,
don't know if this one's still in use, but when I was growing up, like there will be more eye contact where things
yeah,
really like will sit still, will keep, you know.
yeah, we are not supposed to be doing that anymore. It's taken a while though. When I was in when I started grad school in 2000, I was in an early childhood learning center for practicum, and one of the supervisor was still saying, "Look at me," but we learned quickly that we're not doing eye contact goals. And that has been thanks to advocates and autistic people who've told us that that's not helpful or useful, right? The 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 eye contact goals, so we shouldn't be seeing them. We still see them, right? Now, like during evaluations, like if you're evaluating for play, joint attention, things like that, you might see eye gaze. They're just looking to see if the child follows your gaze if you point somewhere, right? Um, or if the child is communicating with their eyes. So a child might look at a toy and then look at you, look at an adult, and then look back at the toy. What they're saying is, hey, look at this, right? They're sharing joint attention. So that type of triangulated gaze, right? But if you don't see it, you're not supposed to say, we're going to write a goal for a child to do the triangulated gaze. No, eye gaze is descriptive during the evaluation to see if they're using eye gaze to communicate. But beyond that, should not be writing goals for that. Now, you know, when we're trying to teach people to communicate, orienting to the face is, important, um, because they might be able to see your mouth, right? To see what you're saying. Some people learn by looking at your mouth, not your eyes. So you might do things like hold a toy up by your face to have them orient to your face. But, we shouldn't be seeing goals for that. As far as social skills. In speech pathology, we've been doing social skills programs for a while, and that is something that's changing. Um, so, especially for girls, um, because girls tend to mask a lot, right? And so it's like, oh, you've succeeded at these social skills because you act like a neurotypical person, right? But in that process of, doing these social skills of neurotypical people, they're masking, and that's a lot of pressure and stress on some people. So there are social skills, there are benefits to social skills programs. The thing is that it needs to be a goal that comes from the student, something they want. If they want to, if they say, hey, I have a job interview, can you, teach me some strategies to get through the interview, that's one thing. Or prom is coming up. I want to know how to ask someone out, to go to prom with me. But, having, the students go through a social skills program and learning all of these things, it's I haven't seen research yet that's showing how it's generalizing. My son went through social skills programs, and the teacher was like, wow, he's the best one in the class. He knows everything to say. He's, passes with flying colors, and they wanted to dismiss him from the IEP. And I was like, no, he still needs an IEP. He's not turning in his stuff on time. He like he needs the IEP for his ADHD, really. I mean, before you throw everything out just because he's does well, he knows to say please and thank you. He knows, and it works with adults, right? I told her, I was like, he still doesn't have friends his same age, right? So it was like the social skills program hasn't helped him with that. And so I said, what about generalizing these social skills to the gen ed classroom? Like in the morning, they have smart block for like 15 minutes, and it's all about, and this is for all of the kids, social emotional learning. So I said, how about we tell the teacher these are the goals he's been working on as far as socialization, and have the teacher facilitate, him, just socializing with his classmates. Instead of just saying, oh, he passed all these social skills, he knows what to do. It's like he doesn't apply them. Instead, I think that SLPs, it would be great if we could help facilitate friendships. Um, and not just the peer, typically developing kids, because they don't necessarily ask the autistic kids or neurodivergent kids to go to a movie after school, right? They'll be really nice in school during these, one of the SLP suggested doing like a lunch bunch with other neurotypical kids. And I'm like, that's a great idea. He needs to be introduced to other kids with the same interests, other kids who may communicate the same way. I'd much rather have you all spend the time trying to get friends with people who are like him than teaching him how to act quote unquote normal. So more and then also things like teaching him to recognize uh fake friends, right? When there are people trying to take advantage of him, people, because he tends to be pretty trusting, some would say gullible. And so it's like, we need to be able to teach our kids to recognize that, you paying for ice cream every day after school, that's the reason why they invite you along. You need to know that that they're being tricky, or teaching him to advocate for himself. Those are the types of social skills I think would be useful. And then maybe if they ask for something like, I want to know how to ask someone out on a date, or um, so I during my postdoc, I worked with there was a PhD student who was autistic, and I asked him, I said, what do you think? Do you wish you had had social skills growing up? And he said, yes, I do. And he said there are individual differences among autistic people. Some of us want to learn that stuff. Um, and there's certain things you need to learn to keep a job, right? I needed to tell my son that, you don't stay home just because of a sniffle, right? If you keep calling in sick, you're gonna get fired. And so we're teaching them the particular things, reasons to stay home. There's certain illnesses where you should stay home. But if it's mild, that is going to make your boss mad, and then you'll get fired. Things like that, things like asking off for work that, don't assume because you ask us for a holiday, they're going to give you the week off. You have to wait to hear what their response is. Things like you know, uh, asking for help. Those are, some what we would consider, typical job skills that everyone needs to learn. Like I started bussing tables when I was 15. I learned a lot in high school working in a busy restaurant, and made mistakes then that I'm glad I didn't make when I was grown and in a real job that could have gotten me fired. Um, you know, those are the types of things, like the PhD student, he said, interpreting emails, like my PhD, my postdoc mentor, she would write like one sentence responses in her emails. And like he said to me, he's like, I don't think she likes me. I was like, no, she does that to all of us. And she has this new iPhone, and when she's replying from her phone, those are extra short. It's just like when she's emailing from the phone, it's gonna be really brief. But, and he was like, "Oh, I thought all this time she didn't like me." And it's like, those are the types of things, right? Interpreting those things and, those, I guess, unwritten or nuanced, social cues. Um, I think that, autistic people and even people like me, because I've misinterpreted emails before too, would want to know about. So I don't think we should throw all social skills or reading typical social cues out with the bathwater, but the goals really should be generated from the client. And I think that we can be more helpful with like advocacy, being able to tell when others are being deceptive, things like that, and helping them make friends.
I love that answer so much. One thing that stuck out is um I think something you mentioned about social emotional training being for all children. I've had this idea that in an ideal world, yes, autistic people would learn about non-autistic communication because non-autistic people are valuable too. But that it would go both ways. That it
Yeah,
wouldn't only be here's what most of the world does, and autistic people like have these special classes to learn about it, but also non-autistic people having classes about how to learn about autistic communication. And maybe even a little bit more emphasis on that just because statistically there's more non-autistic people, so like they won't have to mask as much in interactions
right.
because they won't be interacting as frequently on average with autistic individuals. And then the sick policy thing you mentioned, that's I've
Yeah.
always felt that places should have like a special autism friendly version of the sick policy because
Yeah.
it's so unclear, like how many times do I need to cough before it's like if I cancel for one cough, then that's not good. But if I show up and I'm coughing 100 times per minute, then I'm in trouble in a
Exactly.
different way. So it's I need the
I know.
specific like cough per hour threshold there.
Oh my gosh. Yeah. And my son would be very specific on that. So, but it's the advocacy that we want to teach our college students is to get the accommodations for things like that, because we have kids coming into college who've never had, um, they've had an IEP, but they didn't have the autism diagnosis, or they, may have had it for something, but they didn't have it for the anxiety. And so then they ask for, or they don't ask for accommodations, or the ADHD is a big one that we're getting a lot of now. And our faculty, they don't seem to know, and I'm talking about in general, what to do with these requests of that I can't come to class. And to me, I'm like, we have the technology. I could turn on the Zoom, whereas there's some really entrenched faculty who do not want to do that. But what I don't like seeing is our college students failing out of school because they didn't get accommodations, um, or because the faculty didn't honor their accommodations. So that type of advocacy, my son is going to go to a camp this summer at the Duke Marine Lab in Beaufort for a week. This is going to be his first time by himself away for a week. Um, and it's gonna be like a marine biology camp. And I'm just concerned if the teachers are patient, if they've ever had an autistic child in the class. I don't know, but I just think that, we need to help him with, expectations of coming to class on time. Of course, I'll call him in the morning, but to make sure he's up. But if he's not feeling well, how to tell the teacher. I mean, there's just a lot of things thinking about him being off on his own, and he's only in eighth grade, but college is coming up soon, so I want him to be able to tell the teachers, any accommodations he might need. because, and as a professor, I can't tell a student, you need accommodations. I can tell, you have ADHD. I can't do that. I just have to sit and listen. And, there are some times where students have no idea, right? They don't realize. I didn't get, my ADHD diagnosis until a year ago, right? So I didn't know. But it's on the other hand, faculty, we can't tell, students what to do, and we can't tell them. But hopefully in grade school and high school, the SLPs can be working on advocacy and, just being proud of who they are and not ashamed. So when they go to college, they get the accommodations that they should be getting.
Thank you. And then the last question I had is, what do you think is the most common cause for or reasoning behind the resistance to accommodations? Like if a teacher or a professor or a school system pushes back on an accommodation that's requested or doesn't prioritize it, what do you think is the root problem there? And
It,
I'm sure there's like no easy solution to that, but like, are there any specific things that you think might mitigate that resistance?
yeah, the main thing is it's teaching different ways for different students in general is hard to do, like if you're at a school where everyone's a 4.0, then, pretty easy. Uh, but if you are teaching, if there's not a bimodal curve, you're teaching to a lot of different types of learners, that's more complicated. And so I think that's one of the main reasons why people faculty, teachers, IEP teams may be resistant. I know in the school systems, the public school systems, money is an issue um, for things like a speech generating device. Traditionally, each one costs $5,000, and the school may not want to let the student take it home. Um, but they're supposed to be that's their way to communicate. They need that all day. Now we have apps, so a $600 iPad and a $300 Lamp Words for Life application greatly reduces the cost, but still, there are not a lot of speech pathologists who feel comfortable setting that up. Districts will have assistive technology specialists, but there aren't a lot. So there's a shortage of personnel to do certain accommodations. Money is an issue. And then it's just more complicated to be able to teach people different ways with different accommodations. At the beginning of every semester, we get emails from student accessibility services telling us the accommodations for each student. And they really aren't that difficult to implement. They really aren't asking for, there's technology to help people, who are blind. If there are a lot of different, there's technology, and then we can do accommodations giving extra time. Part of the reluctance on with college professors, however, with things like extended time is saying, well, in real life, once you get a job, they're not going to give you an extension. If you work in the acute care unit of a hospital, you don't get 2 weeks to do your notes. You have to do it then. That has been a lot of the reluctance among speech pathology faculty, students who may have disabilities, a student who's a stutterer. Um, we have speech pathologists who are stutterers, we have faculty who are stutterers, but still to this day, there are students who are pushed out of programs because their supervisors, they don't know what to do as far as how to accommodate the disfluency. A student may have a lisp, and so the faculty will say, well, how can someone who has a lisp work in a school if they can't model the S? Well, they need to know that there are things such as recordings, they can play a recording of the model of the sound for the student. The thing is, like, none of this information is centralized for us to know. I think a strategy is going to needs, the American Speech Language Hearing Association, they need to tell us, how do you get a stutterer through a program without making them do harmful stuttering therapy? Um, we know it's been done, but in general, people don't know what to do. So I think the solution would be better training on how to work with specific populations. Um, and then as far as accommodations, like using, we need to relax our policies. We have a lot of policies that put barriers up for students. A policy saying you can't use Zoom outside the pandemic, it's putting up barriers for students who can't come in person. And we just have to decide that if that we're going to give that accommodation. If there situations where we're still beholden to our clients, right? Our ethical guidelines to provide the services for the client. So if it's detrimental to the client to give the student an extension on their notes, that's one thing, but we need guidance on how to do that. Some clinical supervisors, they have the attitude that I'm the one who has the license. Ultimately, this is my client. So if my student is not able to do the SOAP notes, I have to do it. Um, that's one way they've gotten around it. But the downside of that is that that student doesn't learn to do it if their supervisor is doing it. So there's just a lot of first, programs need to commit to, uh, you know, accommodating students who learn differently. Um, and then, as a field, we need to provide more guidance to the faculty. Um, I really think it's a money issue in the school districts, and lack of resources is part of the problem. Um, and teachers, they have huge classrooms, they're overworked, and they may see these accommodations as one more thing they have to do. We also need to pay special ed teachers more, period. I mean, we're expecting children to be integrated into mainstream classrooms more, and so we need to provide the training for the gen ed teachers.
Yeah, I think those are all. I really wish that we can see teachers be paid more in general, and especially,
Yes.
um, especially
Yeah.
if the funding is able to be used to ensure
Mhm.
that children get one-on-one aids when they need, or I guess just
Yes.
generally better ratios.
Mhm.
Um, well, thank you so much for your time and for
You're
explaining
welcome.
your research. It's really interesting. I had read like snippets of your paper before, but having it explained in more detail was really neat to learn about. So thank you
Okay.
so much again.
Oh, no problem.